Yeah. Hi, everyone. I'm Abbal Koirala. I'm a clinical assistant professor at Harborview and Montlake. So my topic for today is rituximab and MCD and immune-mediated FSGS. I've tried not to include slides from the pediatric literature, and I'm not going to talk about data from the pediatric world. So it's mostly going to be adult world. And when I say FSGS, I mean immune-mediated FSGS. So let's start with a case. So this is a 24-year-old fourth-year medical student with minimal change disease. And this is the proteinuria trend over time. When he was 19, he had 25 grams of protein in the urine, albumin was 1, had edema, had a kidney biopsy which revealed minimal change disease, got induced with prednisone 1 milligram per kilogram, so which was roughly 60 milligrams. And then he attained remission, complete remission, which would be proteinuria less than 300 milligrams. And he remained in remission until 12 months later when he had 15 grams of proteinuria in the setting of influenza, right after influenza vaccination. And then he was again treated with prednisone and again attained remission, as you can see, with UPCR less than 300 milligrams. And he remained in remission until 28 months later when he had a relapse with urine protein of 20 grams. This time he was again reinduced with prednisone 60 milligrams, but it took him a while before he attained remission, more than 6 months. But then he was able to attain remission. And when with the prednisone taper, when he was on 5 milligram daily, his UPCR started to increase from 0 to 50 to 100 to 300. It increased to 5 grams and it peaked around 5.5 grams. And then he was placed back on prednisone, 60 milligrams daily. He does not like prednisone. He used to be this man before, and then with prednisone and all the side effects of steroids, he has developed Cushing syndrome. He does not want to be on cyclophosphamide, and he's heard all the side effects of calcineurin inhibitors, not to mention increased risk of relapse upon tapering of calcineurin inhibitors. So he wants to know more about rituximab. He's heard about it, but wants to know whether he would be a good fit for the medication. So these are my learning objectives for today. So number one is to understand the mechanism of action of rituximab in primary podocytopathies, to understand the role of rituximab in adult treatment-naive MCD and FSGS, as well as frequently relapsing and steroid-dependent nephrotic syndrome, and to understand the role of rituximab in steroid-resistant nephrotic syndrome. So this is the first question the medical student is asking to a nephrologist. So the first question is, please walk me through the role of rituximab in primary podocytopathies. So when we think about primary podocytopathies, we think of minimal change disease and FSGS, and they are part of a continuum. MCD being a disease where like in a lab, if you give a chemical like puromycin aminonucleoside, depending upon the dose, whether you can induce either MCD-like lesion or an FSGS-like lesion. If the lesion is mild, you get podocyte foot process effacement, opening of the slit diaphragm and proteinuria, and when the injury resolves, the podocytes can revert back to their normal shape. If the injury is severe, the podocytes can detach and get lost in the urine. So all of these diseases vary in terms of the degree of podocyte depletion, and all of them vary in terms of how likelihood they are to undergo remission with steroids and how sensitive they are to steroids. All of these lesions eventually can lead to FSGS NOS. And if you lose 30 to 40% of podocytes in the glomerulus, that glomerulus is gone. It can lead to global glomerulosclerosis. And when enough glomeruli are lost, that can lead to ESRD. And the disease, especially FSGS, can recur in the allograft after transplantation. From immunological perspective, these diseases are immune-mediated diseases. Initially, we only knew about the role of T cells in these diseases. So infections, immunizations, malignancies, and drugs would cause polyclonal T cell activation. And they secrete chemicals, cytokines called permeability factors, which then can affect the podocytes. So this was the classic Shell-Hoop hypothesis, where it's postulated that cell-mediated immunity is the culprit in minimal change disease. And if you give a kid a disease like measles, that would lead to remission of nephrosis. And because you don't see staining for immunoglobulin or complement on kidney biopsy usually in the setting of minimal change disease, it was thought that T cells are the only ones that are important. And these permeability factors can act via different mechanisms. Some like SUPAR can act via beta-4 integrin receptors. Some like interleukin 3, hemopexin can bind to their receptors on the surface of podocytes, leading to actin cytoskeleton disarray. And some like glomerular permeability factor not otherwise specified can alter the charge barrier. The glomerular basement membrane is negatively charged because of anionic glycoproteins. So if you make it more positive, then that would ease the passage of albumin in the urine. Over time, we've known that B cells are equally important, and the relationship between T and B cells is bidirectional because B cells are also antigen presenting cells. And as with any autoimmune disease, what we've known is it's often a balance between effector cells and the regulatory cells. So often in the setting of podocytopathies, you get regulatory T cell as well as regulatory B cell dysfunction. And there's more activation of TS17 cells or the cells that mediate autoimmunity. A lot of the drugs like steroids, cyclophosphamide, calcineurin inhibitors, and rituximab act at the level of T and B cells, but a lot of these drugs also have direct podocyte action. So in addition to these mechanisms, in the last couple of years, we've had several discoveries in the minimal change disease FSGS world with the discovery of 3 antibodies. The first one is the UCHL1 antibody, which is ubiquitin carboxyl hydrolase L1 antibody. And this was discovered in French cohorts. So they had 85 children um, with idiopathic nephrotic syndrome and 76 controls. And it was found that if you look at the graph, anti-UCHL titers, it was found that children with idiopathic nephrotic syndrome relapse had higher titers compared to children in remission. And when these children were treated with different drugs, their titers decreased over time. When you look at the immunofluorescence microscopy, UCHL1 is stained in green. So you can see some nuclear staining and some staining of the endoplasmic reticulum. It's thought that the UCHL1 is involved in the deubiquitinylation of proteins. So it's a negative regulator of proteasomal pathway. So when the antibodies are there, the proteasomal pathway gets activated and it leads to downregulation of nephrin and other slit diaphragm proteins. The second antibody was discovered in a cohort from China called anti-annexin antibody. So in 596 children with primary nephrotic syndrome in China, you can see the titers were present in 17.8% of these children. And they were not seen in children with henoch-Schönlein purpura, IgA nephropathy, lupus, or normal controls. And when these children were treated with different immunosuppressive medications, these antibody titers decreased over time. You can also see the immunofluorescence microscopy where the green is IgG, anti-annexin antibody is in purple, and nephrin is in red, and you can see all of them overlap. And it's thought that annexin A2 antibodies lead to via RAC and CDC42, they lead to downregulation of nephrin and ZO1. Those are the 2 slit diaphragm proteins. And then that in turn would lead to nephrotic syndrome relapse. In the adult world, we've had discovery of anti-nephrin antibodies, and Dr. Lekka had spoken about it last week. So this was a Neptune cohort where 29% of the patients had anti-nephrin antibodies. So and the cutoff was more than 187 units per ml. And you can see these pictures, immunofluorescence microscopy pictures. Red is staining for nephrin, IgG is green, and all these yellow dots are anti-nephrin antibody staining. And when these patients were treated, the titers of anti-nephrin antibodies decreased over time. Rituximab is a monoclonal antibody. It's until 2016, it was the most commonly used monoclonal antibody, and it has revolutionized the cancer world. And we've been using it in a lot of autoimmune diseases. So rituximab, how it's generated is that mice are usually challenged with the antigen, which is CD19, and you harvest the spleen cells, and you fuse them with immortalized cells called myeloma cells, and you create these hybridomas. And you culture these hybridomas in HAT medium. Because myeloma cells lack HGPRT enzyme, unfused cells die, and you select these positive cells, and then you harvest these monoclonal antibodies. Rituximab, as a monoclonal antibody, has these red sites, which is the variable regions of both light and heavy chains. So this is murine, whereas the FC region is fully humanized. So it's not completely humanized. It has mice variable regions. So because of that, you can develop allergic reactions to the infusion of rituximab, as well as you can form anti-rituximab antibodies. And the way it kills B cells is via different mechanisms. So one of them is complement-mediated cytotoxicity, where rituximab binds to CD20, which in turn causes activation of classical complement pathway and formation of membrane attack complex and lysis of B cells. Rituximab via FC receptors is taken up by macrophages, and that causes antibody-dependent phagocytosis. And rituximab binding to CD20 uh, can be taken up by the natural killer cells, and they in turn via perforin granzyme pathway can cause direct lysis of those cells. So this is the structure of CD20. So you can see you have 4 transmembrane domains. This is the N terminal, this is the C terminal, and CD20 has 2 loops. This is the long loop, and this is the short loop. And rituximab binds to the long loop of CD20. The newer humanized monoclonal antibody like ofatumumab bind to both short and long loop of CD20, and that's the reason ofatumumab is thought to cause prolonged B cell depletion. So far, I've illustrated different ways how rituximab may work and how it would be beneficial in primary podocytopathies. So this is the summary. So rituximab would deplete B cells, but B cells are also antigen-presenting cells, so it would also decrease effector T cell number. And rituximab would increase the expression of B regulatory cells, so it alters the balance between regulatory B and T cells in favor of regulatory B and T cells. Rituximab because of decrease in the expression of polyclonal B and T cells, it also causes decreased formation of cytokines and permeability factors, which in turn affect the podocytes. And finally, podocytes have these receptors called SMPDL3 beta, which mimics CD20 receptors. And rituximab binds to these receptors and stabilizes SMPDL3 beta, so you don't get actin cytoskeleton disarray. So there's also direct action at the level of podocytes. So the second question the medical student asks is, has rituximab ever been used in de novo or treatment-naive MCD? And it has been. So this is a study from 2018 where 6 adults with de novo MCD were treated with the rituximab. All of them were not treated. All of them had contraindications to steroids, so they were not treated with steroids, and they had almost 12 grams of urine protein, and albumin was 2 grams. And rituximab was used as 375 milligrams per meter square per week for 4 doses. And you can see the proteinuria trend over time. Almost all of them underwent remission. So complete remission would be UPCR less than 300 milligrams. And one patient had more than 75% reduction in proteinuria after 9 months. So it does seem that rituximab works in de novo disease. We just need more data. What about FSGS? So the third question the student asks is that if rituximab has ever been used in de novo FSGS. So this is a study from Spain where 8 adults with de novo FSGS were treated with rituximab. The albumin was 2.75 grams per deciliter. Baseline proteinuria was 5.3, and baseline creatinine was 2.6. The first graph is the trend of serum creatinine over time. And you can see the serum creatinine increased over time from 2.6 at baseline to 3.5. And the proteinuria did not really, I mean, you did see a trend. So from 5.3 grams at baseline, it only improved to 3.9 grams per deciliter. So barely partial remission, which would be defined as UPCR less than 3.5 grams. There was only one patient who attained partial remission after 18 months. And rituximab, patients were treated with rituximab 375 milligrams per meter square per week for 8 doses. So the fourth question the student asks is if rituximab has ever been used in relapsed MCD and FSGS patients. And this is where most of the data is there in the adult world. Unfortunately, we don't have randomized controlled trials so far. In the pediatric literature, we do have randomized controlled trials, but we have a lot of observational studies. So this is a meta-analysis from 2020 where there were 18 studies with MCD, 170 patients, and these patients had relapsed MCD. So they had 3.6 grams of protein in the urine. Creatinine was 1 and ACE was 34. The median dose of rituximab was 1,500 milligrams per meter square. So you can see rituximab improved overall remission, and the remission rate was 80%. 74.7% of the patients attained CR, complete remission, and 5.6% of the patients had partial remission. The relapse rate was 35.9%, and the median follow-up was 27.6 months. There were 5 studies with FSGS, 51 patients. They had 5.9 grams of protein in the urine. The average age was 40. And rituximab did help in attain remission, and the remission rate was 53.6%, with the CR of 42.9% and partial remission of 11%. So you can see the overall remission was lower in FSGS compared to MCD of 80%, but the confidence intervals overlapped and it was not statistically significant. The relapse rate in FSGS was 47.3%, and this was not different compared to MCD and was not statistically significant. They also analyzed, whether the dose of rituximab had any bearing in terms of relapse risk or overall remission risk, and there was no difference. What about patients who've been in remission and who've received rituximab? This is the fifth question the student is asking, if rituximab has ever been used in patients who are in remission. So this is the classic NEMO study from Italy, where children with frequently relapsing and steroid-dependent nephrotic syndrome received rituximab. They only received 1 or 2 doses of rituximab, and the average urine protein was 0.12 grams per deciliter, and albumin was 4. So you can see that a lot of these patients were on different drugs at baseline to maintain remission, but after 1 year, they were able to get off of those drugs. So 95% of them were on steroids before they got rituximab, and at 1 year, only 46% of them were on steroids. 32% were on cyclosporin before rituximab, and only 0% were on cyclosporin at 1 year. And 4.5% were on azathioprine and cyclophosphamide before rituximab, and only 0% were on 1 year. And all of them attained remission, but the primary outcome was the relapse risk. And you can see in overall 30 patients, as well as in 10 children and 20 adults, as well as in patients with minimal change disease and FSGS, rituximab reduced the number of relapses over time. So if they had more than 2.5 per patient median number of relapses, rituximab reduced the number of relapses to 0.5. So the sixth question the medical student is asking is if there's an ideal dosing for rituximab. I mean, we borrow rituximab dosing from the lymphoma world, and classically we've used 375 milligrams per meter square per week for 4 doses. In the outpatient world, we often use a gram 2 weeks apart, and then people have even used 375 milligrams per meter square per week for 1 or 2 doses. They've just and some studies have only used a gram once. So it's still not clear, but there are two trials that we need to watch out for, randomized controlled trials. So the first one is Turing. Hopefully the paper will come out in a couple of years. So this is a trial from the UK, where the University of Cambridge is partnering with NHS, and they are testing rituximab in de novo, meaning treatment naive or relapsing nephrotic syndrome. So all of them will get prednisolone to attain remission, with taper after they attain complete remission. And at 4 weeks, they'll be randomized to either rituximab a gram 2 weeks apart or placebo, and they'll receive another gram of rituximab at 26 weeks. And the primary outcome is time from partial remission to relapse. The second trial to look forward to is Rifarians from France, where they're testing rituximab in relapsing MCD and FSGS. So they'll be receiving prednisolone with taper, and at around 8 weeks, when they attain complete remission, they'll either receive rituximab, uh, 2 doses a week apart, or placebo. And if they have gotten rituximab, then the prednisolone would be tapered over 9 months versus the standard taper after 24 weeks. And the primary question is the relapse rate between the groups 12 months after randomization. The seventh question the student is asking is if there's a role for rituximab in steroid-resistant disease. So this is a classic retrospective study from Spain, where there were 8 adults with FSGS who had persistent nephrotic syndrome, and all of them had failed multiple immunosuppressive drugs. The median disease duration was 47 months. The mean proteinuria was 14 grams. Albumin was 1.75 grams, and mean creatinine was 1.4 milligrams per deciliter. And they were all treated with the standard lymphoma dosing, 375 milligrams per meter square per week for 4 doses. And this is the proteinuria trend over time. You can see most of them did not respond. So the mean proteinuria was just 10.5 grams at last follow-up of 16.4 months, and the mean creatinine was 2.2 grams. Only 3 patients responded. One in green had a response initially and then relapsed and then responded again at 12 months. This one in blue had a really good response from more than 20 grams of proteinuria at baseline to 3.9 grams at last follow-up. And the second patient with 12.9 grams of protein was able to attain partial remission, which is defined as UPCR less than 3.5 grams. So the last UPCR was 3.2 grams. So all of them had a response, and they received extra doses of rituximab. So the question is, is that dosing enough or to overcome steroid resistance? Do they need extra doses of rituximab? In the pediatric literature, there is data that those who are steroid resistant, you can make them become more responsive if you give them extra doses of rituximab. The other thing is rituximab is a monoclonal protein. It's an immunoglobulin. You do lose it in the urine. On one hand, you have direct antipodocyte actions, but the half-life is reduced in nephrotic syndrome. So Fernando Forveza did a study of rituximab in membranous nephropathy patients with almost 12 grams of protein, and the half-life of rituximab was reduced to 12 days compared to 18 days in rheumatoid arthritis. So maybe these patients would need extra doses of rituximab, but it's still not clear in the adult world. This is a second study from this year, coming out of Mayo Clinic, where they treated 9 patients with FSGS who had SUPAR more than 3,500 picogram per ml. And they also had activation of beta-3 integrin activation. So SUPAR acts via beta-3 integrin and causes podocyte cytoskeleton disarray. So, the podocytes were cultured for 14 days, and the patient's sera were added, and the podocytes were then stained for AP5 antibody, which is a marker of beta-3 integrin activation. And only those patients were selected. And all of them received rituximab a gram 2 weeks apart. The mean age was 37. The mean proteinuria was 7.7 grams. The mean GFR was 67, and all of them had, been heavily exposed to different immunosuppressions in the past. And you can see the GFR declined over time. It was a 12 months follow-up, so it decreased to 60. One patient progressed to ESRD, not a really lot of change in the urine protein. The urine protein was only 7.2 grams at last follow-up. One patient had a partial response and one had a complete remission at 6 months, but then all of them then worsened at 12 months. So, and then Rituximab.
We are going to move on, and hopefully if there's a few minutes at the end for Abbal to retake the microphone. But with that, we can move on. Abbal, you may have been answering some questions to individuals. There's some questions for you in the chat, maybe for those who can stay on for a moment.
I can't see that part. I guess my screen was frozen and then.
No worries. I'm curious about it's interesting to me to think that the pediatric world often relies on adult, has to translate adult trials for application in pediatrics. And here we have kind of an opposite situation. So I'm curious about how you kind of think about the existing literature in pediatrics. But Lauren Hawkins also asked, in adults with nephrotic syndrome, is it standard to have biopsy confirmed diagnoses of minimal change versus FSGS? They often don't do biopsies in kids.
Yeah, I mean, that's the practice in kids. So, unless they're steroid resistant or they haven't responded, that's when they do the biopsy. But in the adult world, we often biopsy patients. And I think with Rituximab, there's data in the adult world, but most of it is observational retrospective studies, not from randomized controlled trial. And even though we have been able to get Rituximab for some of the patients, it's really hard to get them covered by the insurance company. I mean, our best bet is, somebody who has frequently relapsing or steroid dependent nephrotic syndrome, just so that we can taper the other immunosuppressive medications. But often the bottleneck is the insurance company.
Great. And Stuart had asked earlier on whether there are any biomarkers to guide your decisions about whether Rituximab is appropriate treatment besides DUPAR.
Yeah, there are. Should I just share my slide? I mean, I had one on that. So this wasn't one in one of my slides, but can you see my screen?
Yes.
Yeah, so the proteinuria selectivity index has been there since 1960s. It's the urinary clearance of IgG to urinary clearance of transferrin, and then highly selective PSI with PSI less than 0.2 or even closer to 0.1 would be minimal change disease.
Abbal, we've lost your audio. Is that the case for others? Yeah.
Baseline, they were more likely to attain complete remission. And those who had a higher proteinuria selectivity index, they were less likely to undergo remission. So that's one that we can follow. Plus, likely if they have lower PSI at baseline, very likely they have either minimal change disease or frequently relapsing nephrotic syndrome.
Thank you. Well, thanks to everyone. Great talks, great discussion. I'll look forward to seeing those of you that are able to attend in person next week down at the VA. Have a good weekend.